Um, it's really it's really been a pretty extraordinary journey, even just the last few months, but even longer than that, the last few years of working, you know, with Jim McDermott's office initially. He had the first state-based universal healthcare legislation. David Loud, who's not able to be with us tonight. Many of you know David, who's in Washington State. He was a staffer for David Loud. And so he brings and he's part of our work group, and he brings us this institutional history, which is very important. And then when Jim McDermott stepped away, Pramila Jayapal, who was his successor in the House, stepped in and carried the state-based universal healthcare legislation, changing it considerably to the point where it's very similar. The bill right now is the one that Pramila revised back in, I think, 2017-18. And it's notable to say right out front here, with Pramila being the prime sponsor of the National Medicare for All bill, being the successor to John Conyers, is that she's the first co-sponsor on the State-Based Universal Health Care Act. Some people think that we're in conflict with the state-based work and the national work, and my pushback is by no means. This is complementary. We're actually building toward a national successful system, and just you have to look no further than our friends to the north in Canada, where Saskatchewan was the first province to go over the top. And that model was the envy of every other Canadian province. They saw what universal healthcare, what single payer healthcare meant to that province. And so that's how Canada got to national healthcare. It's important that people acknowledge this and share this. It's an important story coming out of the 1960s. It dates back to the 1930s, but the success comes in the 1960s. And then also to see that our constitutional framework in the United States is very similar to that of the Canadians. It's the design of our Constitution to have shared powers between the national and the state governments, and states have long been seen as the incubators of change, of modeling. The entire progressive era is defined that way. The New Deal era was defined that way. I mean, progressivism began in Milwaukee and then went statewide in Wisconsin, and then TR brought it to the national level. But he could not have done it without those earlier predecessor models of social, economic, and political change being established at the municipal level and then at the state level. I think, Dave, can you mute just a little bit? I think we're just hearing, I'm not sure where the shuffling is coming from, but if you could just mute, that'd be great. If folks aren't muted, maybe just mute yourselves. So it's important to acknowledge our history. It's important to acknowledge our constitutional framework. It's important to see examples of how these systems have been adopted in other federalist constitutional societies. It's also important to recognize the power arrayed against the implementation of single payer right now in Washington, D.C. This isn't to be negative. This is just the reality of the situation. The four horsemen from hell, as I refer to them, the medical device industry, pharmaceuticals, big hospitals, and insurance are absolutely complicit, not only in trying to tear down what does remain of our public health care, but to do everything in their power to stop what it is that we're seeking to achieve. So this is political reality, and I've taught this stuff for 30 years. I'm not going to be the condescending college professor here, but the reality is that our political and industrial complex is very challenging. And what that means is that we have 50 states plus Washington, D.C., which is our last continental colony, but we have 6 more of them abroad. But these are all places where we can model successful universal healthcare systems, and that's what we're doing. And I would just also share on background for those of you who don't know, I ran for U.S. Senate back in 2006, a Democratic nomination in Pennsylvania. And I didn't really understand single payer, but I brought people onto my campaign who did. We sat down in 2004 in running up to the election itself, and I was taught in a classroom setting, what this healthcare system looks like, why it works, and why you need to run on it. And I ran very hard on single payer as a federal program, right, running as a U.S. senator. And out of that election, I got 11% of the vote, and people would come up to me and they say, "Chuck, we're so sorry you lost." We didn't lose. we actually launched a statewide campaign as a result. We brought together the activists who were involved on the campaign, and single payer was the issue that was that seemed to most resonate with our core activists, and it seemed to be the issue that touched most deeply on most people's, on the greatest number of people's lives. So I just give you that context and background to explain in part why I do what I do and why One Payer States does what we do, is that we're very agnostic, we're very opportunistic, and we look to see, how we can move this process toward getting us to national single payer along as quickly, as expeditiously and effectively as possible. So that's just some background I think that might be helpful for understanding why we do what we do. So why don't I share a couple documents, and this will explain, in brief, what State-Based Universal Healthcare Act is about. I mean, in brief, it's designed to get the states the necessary waivers, financial and legal waivers, to go forward as seamlessly as possible in implementing their universal healthcare plan. And right now, Oregon and Washington, in my view, are the two leading states. So let's take a look at those. Let's see. ERISA and SBUHC. Okay, let me screen share. Mike, I have co-host, right?
Yeah, go ahead. You can slide. Yeah, you can show.
Okay, let me do the SBUHC talking points, and then I'll stop and take any questions. And we'll just whip through both of them. Why don't we do that? And then we can open it up for questions. Unless, Dave, you tell us when you're ready to go as well. Just throw up your hand so we know. Maybe we do my presentation and yours and then do questions, or do you want to do mine and then questions? We'll just play it by ear. Okay. Okay, so thanks again to, I believe we're talking Sam Metz, Charlie Swanson, and Chris Curry for being the primary drafters of this document. A number of other members of the meeting of the work group had a little bit input, but those are the three primary authors. So I just want to give a shout out and thanks for their great work. So you can see that this was drafted back on March 1st, and one of the reasons we drafted it, frankly, was to remind ourselves why we're doing this work, to be very clear and succinct, and also to help educate healthcare legislative aides that we're going to be working with, beginning with our dear friend now, Emma Preston, who's in Representative Ro Khanna's office. So we start out with a statement here that what is the value of single payer in terms of its financing? One of the tricky things that we have in our campaigns and our movements is that single payer really is an insider term, and I don't like using it publicly, but I think most of us know single payer refers to the financing aspect of universal healthcare. But the delivery side needs to have a better way of being presented conceptually in terms of framing. But single payer is unique in that it creates a dramatic reduction in billing and collection, as the document says, and this is what enables us to be able to provide universal healthcare. So the billing and collection reduction from roughly 30 to 10%, diverting enough money again to provide better care to more people, less money, and doing so without reducing net provider income. No other financing format in the U.S. offers this advantage, and numerous studies have confirmed this, including the Lewin Group, which was one of the earlier study groups, and they were bought up by Universal Healthcare of New York and, of course, put out of business. So every economic study that's been done where single payer has been in the mix, single payer has come out ahead without question. We know it works. It's better because of examples in other nations. Not every nation has the same exact system, but they fundamentally have the concept of streamlined administration and savings, and that's really what we're talking about here. Let's see, number of studies. The the question of why don't states take the lead? Well, right now we are. And this is what we're looking at, especially in the Northwest, but the potential exists for Minnesota, Maine, New York, and a handful of other states. So this is how we intend to model, similar again to Canada, to get to a national program. Yeah, single state agency paying all the providers, thus the term single payer. We should be straight up here and let you know that that there are two exemptions in Ro Khanna's legislation. It's HR 3775 from last legislative session. If somebody wants to pop that in the chat, you can at least get a handle on the language. The language won't be released until probably mid-May at this rate. Khan is planning to do an introduction to his members and get them to sign on as original co-sponsors, but HR 3775 is a good place to start just to get the concept. But all payer is probably a more is probably a more accurate way of putting this, because American Indian Health Services are carved out, though the system that will be implemented will wrap around those services, but they're exempted from the waivers, as well as veterans, the VA system right now. So we're single payer is the concept, but all payer is really the more accurate way of putting it. So it'll be about 95+% will be in a single pool. I think that's about right. Does that sound right, Sam? About 95%? Yeah, thank you. Okay, so here are some of the federal programs that need coordination with the state-based single payer plan. Without getting into a lot of detail, we can do this during the Q&A, but Medicaid, originally widows and orphans, this requires states to obtain waivers that they spend money for anyone else. There are some questions we have to tussle with here. Unclear if such a waiver complies with Medicaid statute, but in Oregon, 25% of the population is already covered by Medicaid. So this is a critical piece of the waiver process. Medicare, yeah, highly complex, convoluted, changing. This is another one. We really need to get the Medicare waiver. And this is a document that comes out of Oregon, as you can tell, 15% of that population covered by Medicare. I think the numbers are similar in Washington and most other states, but I don't want to go too far in that assumption. The ERISA is a document the second document we'll take a look at, but again, that's the Employee Retirement Income Security Act. And this is the one that protects self-insuring companies that provide benefits from being meddled with by state agencies or state government. So we need a waiver to protect the state government to implement a system that wraps around all residents of the state. Again, with the carve-out exemptions for Native Americans and vets, but in fact, the system will wrap around them as well after they get their core benefits. Their systems are still in place. So that's ERISA, which we'll talk about in a few minutes. Federal employee health care plans, TRICARE, or other waiver programs that we're going to seek. The IRS, this is a new topic really for discussion in this circle. And this comes to us from our friend Warren George, who I'm working with, interfacing with Senator Wyden's office. Senator Wyden's the senior senator and the chair of the Finance Committee out of Oregon. It's going to, in all likelihood, at the state level, it's going to require a lot of creative taxation maneuvering. And it's probably going to require that federal income tax be part of of those new maneuvers, and therefore we're going to probably need to get a waiver out of the Internal Revenue Service. So that's another line of waiver that we're pursuing. More on that as we go down the line. So what needs to be done to permit state-based single payer plans? Again, what we mentioned here, we need to get waivers from all the above programs. So as to streamline the administrative costs of what is now a multi-payer system. We need to streamline as much as possible. I guess the waivers here, we want to get the waivers done through Congress, which will give it the strongest legal standing, especially if it's challenged in the courts. If we get a waiver through the executive, it could be sunsetted by the end of that administration. So we want to make sure that we get the strongest possible waivers through Congress and signed by the president. Trying to remember how you presented this before, Sam. If appropriate waiver could be obtained, federal waivers have these disadvantages. They're time limited, they're revocable, might not be renewed when different parties take, right, okay, right. So that's in reference to the federal waivers through, I guess, Health and Human Services and other federal agencies. That's why we really want to get the SBUHC bill done. How does SBUHC address these proposals? It requires waivers and exemptions in one application to one federal office. So once SBUHC passes, it's up to the Health and Human Services Secretary, has 180 days to set up a commission. And once that commission's set up, that body will review applications from the states for waivers. Conditions of these waivers for guidance for HHS, Health and Human Services, is that the new system cover at least 95% of the state population. All patients previously covered by Fed programs enjoy benefits at least as comprehensive as the original. Ours, of course, will far transcend that, and the federal debt is not allowed to increase. So, in summary, SBUHC provides a simplified process that permits states to legally pool current federal, state, and private healthcare spending into a single-based single-payer fund, state-based single-payer fund. So that's the SBUHC overview. Let me see if folks have any questions at this point, and then we'll turn to Arissa and drill down a little more deeply. I'm gonna stop sharing, see if folks have any questions. Was that clear, straightforward enough? Everybody good? No questions. Dave, how are you doing? Can you unmute? Let's see, you have two screens. You're unmuted on one. You want to talk? There you go.
Okay.
Are you pretty well set?
Yeah, I think I'm set to go.
Okay, okay.
Chuck, can I just ask one quick question?
Of course, of course.
Because this has been a debate in California. Who in the state applies to the Fed for the waiver? And my understanding, it should go to HHS, and I read the Treasury is part of it. Is it the governor? Who applies for a waiver from the federal government in the state?
I mean, that's a good question. I don't know that that's clarified in the legislation. Sam, do you have any thoughts?
Yes, Lynn, I don't know if there's a nationwide policy. The state of Oregon has applied for two major waivers from Medicaid. And in both cases, the team that went to Washington to officially apply came from the governor's office, and in fact were led by the governor.
Thanks.
Senator Wiener has just introduced SB 770, which is going to have a hearing on April 19th. I put it in the chat, which is lays the foundation for California to apply for a federal waiver for a unified healthcare system. So I don't know how that, if that answers your question or if it's kind of related. But.
Yeah, let's see if we can get some more clarification on that question. But I think it could be any number of representatives from the state, perhaps the commission itself, the task force itself, the governor, the legislative leadership. I don't know.
Chuck, a little more background is waivers to federal programs are issued from the appropriate cabinet office, which is in the executive branch. It's not a legislative application. So it's very likely it needs to be one state executive branch to federal executive branch.
Executive to executive. Okay, yeah, that makes sense.
So I've got a comment related to that.
Can we do with hands? I'm sorry. Is your hand is up?
I raised my hand.
I'm sorry, I didn't see it. Go ahead.
Yeah. So there is actually in each state, there is one entity that is contracted, is the entity that contacts CMS. And so they need to be involved. In Oregon, it's the Oregon Health Authority. There might be others going along with them, but for at least the 1332 waiver, it's going through CMS. And therefore, it would be the entity that already is dealing with CMS that applies for the waiver. Again, the governor can be part of that, but it is actually it is a particular entity within each state that currently deals with CMS. And I don't know if that's still the case with the SBUHC. I actually, as Sam said, there's going to be one, well, as Sam's document said, there's one waiver, but it eventually gets to each secretary for their own part of it. So there's various secretaries that need to be involved. And there's also for the federal employees, there's another entity involved. So
Yeah. Yeah, thanks. Was that Charlie?
yes.
Thanks, Charlie. I didn't recognize your voice initially. Thank you. And thanks for your great work on all this stuff. I mean, one of the things that I've found out that I'm learning, this is a learning curve, I think, for all of us. It certainly is for me. It's humbling. In conversations with folks in Washington State, that I'm learning that the way that their legislation is drafted is that their state agencies can actually begin implementing portions of the universal healthcare system as they are as appropriate. So it could be Department of Natural Resources, it could be the Department of the Treasury, it could be any the healthcare system. So it's kind of a fluid, defined situation. Is defined by the legislature. It's defined in part then by the roles of the agencies. So I don't know that anybody can predict exactly how any of this stuff is going to go down, other than to say, we just keep banging away and just keep knocking on doors, opening doors, climbing through windows, figuring out how we can move this as quickly, expeditiously, and resourcefully as possible. Mike, your hand is up. Mike,
Yes, yeah, I just wanted to point out that there are very strong supporters of single payer who view the state-based effort as almost a racist balkanization of southern states. And so we all need to be thinking of how, and using Chuck's presentation and our own information of how these are parallel tracks and that they are helping each other, as Chuck mentioned earlier.
yeah, thanks for that, Mike. It's not a lot of people who share those views, but it's a more vocal, smaller subset of folks who, are just, I mean, the way I've always looked at this as an historian and a 5-decade organizer is I'm a methodologue. I mean, I'm not an ideologue. I look at what's the best method to getting these things accomplished. Where are the best ideas? Typically, they're across the political spectrum. And how do you have that conversation with people? Well, it begins with listening, and it begins with really understanding people's needs. And so, I think the broader based coalition, the more listening, the more engagement, the better. And then we break down those walls of misunderstanding, some of which are, maybe misplaced, but we're working at that, Mike. So thank you for your work. I think it's the relationship building is a critical component to getting this work done. Not just the policy, not just the legislation. It's the politics. And the remarkable fact that what was the bill that just passed in Oregon garnered the support of 2 Republicans. Which was not expected. It passed out of the Health Committee, right? 5-0.
Yes.
You are correct, Chuck.
That's amazing. And that speaks again to the political acumen and the relationships that have got to be working simultaneously with all of what we're doing on the outside. We need to be working with our partners on the inside. So we're very, very deliberate and thoughtful about our strategy and how we go about this work. So I'm very proud of everybody here doing the work that we're doing. Everybody's got their strengths and everybody's got their challenges, and I certainly have mine. Let's see. you want to flip around to Arissa and talk about that more specifically, or just why don't we bring up Dave McClanahan? He's ready to roll. We'll talk about Arissa more specifically. Dave, I want to give you the floor. And then we can open it up for questions regarding the deprivatization campaigns around Medicare, and also maybe just even mention the VA. I know that's not part of your conversation here, but I was tasked with just mentioning the fact that the Veterans Administration is also coming under an assault. And we had an office hours, I guess it was, recently, Mike.
It was Pissarro presented it, and I put the links to her presentation, Suzanne Gordon's presentation on the privatization of the VA. So look for that in the chart, in the chat.
Right, just to flag that for folks, just to know that the Veterans Administration is also coming under assault. And Suzanne has written a couple of very powerful books, the most recent of which is Our Vets, I think it is. And it goes into some detail about what's happening and what people can do to protect the Veterans Administration from being privatized. That's not part of Dave's presentation, but I just wanted to flag it. Dave, you want to come up and talk about what your folks are doing out in the Seattle area?
Yeah, let me see if I can share the screen here. Yeah, are you seeing any screen share?
Not yet, not so far. And Pat, thank you for the share also on what's happening in California. Does he, let's make sure Dave has co-hosting, Mike?
Yeah, he's co-hosting.
Okay.
I just wanted to point out the presence in our group of Lode Coleman from Georgia, who's a midwife and done wonderful work there in Georgia. And we need her ideas on how to counter this suspicion about state-based universal health care being unfair to southern states.
Thank you for joining us, Lode. You did a fabulous job last month on our discussion around reproductive rights. Thank you for being with us.
Thank you all for having me last month. It is certainly an honor and privilege to sit and listen in this evening. I have so many questions about how we can get Georgia on board. It is definitely an uphill battle. And I think that the narrative that it's unfair in the southern states, it is definitely an agenda behind that, because honestly, our rural areas, which is almost half of this state, healthcare, access to healthcare, affordable healthcare, you name it, it's deplorable here. So I don't understand how it would be unfair, but I'm definitely here to see how we can get Georgia unified.
Yeah, absolutely. And it's, I mean, just for myself, it's been eye-opening to work in the BIPOC South, Black, Indigenous, people of color communities, where I think the vast majority of Americans have no idea the concentration of people of color in rural areas. I think people have this stereotype of rural areas being virtually all white, and that's absolutely not the case in the South. So thank you, Lode, for your great work.